Okay, so maybe we'll get started. My name's Brian Chan, for those who haven't met me. I'm one of the GI docs at the general site. And I haven't spent much time at Centenary, so if I haven't met you, I'm one of the gastroenterologists with a focus on therapeutic endoscopy, and that encompasses everything from ERCP, EUS, luminal stenting, and large polyp removal. I don't do any bariatrics or ESD. If you ever need to get in touch with me, my email's at the bottom of the slide there. Feel free to contact me. And if not, I'm pretty responsive on Epic Chat. So you're probably all wondering what the picture on the screen is. And I, just like you, have no idea what that is really. If you remember, AI has been a big thing in the last little while. GI was actually the first subspecialty of medicine to run a randomized controlled trial in AI, mostly for polyp detection. And I'm sure you've seen the news that ChatGPT was able to pass the USMLE. It did not pass the GI board exam, for what it's worth. And this image was just one of these AI image generators that I asked to create a picture of pancreatic necrosis, and this is what it spat out at us. So I'm not actually sure what this is, but suffice to say, looks like my job is safe for the time being, and our jobs are safe for the time being at the very least. In terms of pancreatitis, it's always fun to get this image. I get this image sent to me at least once a year when we're talking about pancreatitis. And it's kind of a cute cartoon, but it actually does have quite a bit of truth to it. So you've got the gallbladder saying hi to the pancreas, and it puts some stones in the bile duct. And then the pancreas sort of explodes in that last slide. And while this is kind of cute and fun, there's actually quite a bit of truth to it. And just reviewing sort of the pathophysiology of how pancreatitis occurs, the bile duct and the pancreatic duct share a main opening at the ampulla. If you block this opening, enzymes from the pancreas are no longer able to exit the pancreatic duct. And as a result, you get autolysis and autodegradation within the pancreas. And this can lead to significant inflammation, pain, and fluid collections, which is sort of the main topic of our presentation today. So there's three main objectives from this presentation. We want to diagnose and classify pancreatic collections, develop an approach to management and treatment of these collections, and we're going to review the optimal timing of treatment. I don't think this is going to take the full hour, so if you guys have any questions, please feel free to stop me at any point in between. So most pancreatitis that we see is mild. About 80% of all comers for pancreatitis will have a mild pancreatitis. And that are going to be the patients who come in and, they're having a lot of abdominal pain, but with bowel rest and IV fluids. In 1 to 3 days, they're discharged from hospital. About 20% of those patients are going to have a severe course of pancreatitis, and that severe course is really defined by pancreatic necrosis. 70% of necrosis is going to be sterile, and 30% of necrosis is going to be infected necrosis. Of those 30%, you're going to get about a 20% mortality rate. And early infection is an independent risk factor for increased mortality in patients with culture-confirmed infected necrosis. And these are the patients that we're going to try and focus on in terms of what type of interventions we can actually do for them and at what point we can intervene. Any talk on pancreatitis or associated complications in pancreatitis in 2022 and 2023 really can't get away without talking about the Waterfall trial. This was a landmark trial that was published in the New England Journal last year. And it was a multi-center, multinational trial. 18 centers were enrolled, looking at aggressive versus moderate fluid resuscitation for acute pancreatitis. It was goal-directed fluid therapy, and the fluid therapy was adjusted to clinical status. The primary endpoint was the development of severe or moderate acute pancreatitis. And in terms of the aggressive and moderate groups, in the aggressive group, they were given 20 milliliters per kilogram over the course of 2 hours, followed by 3 milliliters per kilogram per hour of Ringer's lactate, versus the moderate group of 10 mils per kg and then 1.5 mils per kg per hour. They were reassessed at 12, 24, 48, and 72 hours. And based on their clinical volume status, the fluid rate was adjusted, as you can see on the screen, for hypovolemia, normovolemia, and hypervolemia as appropriate. As I mentioned, there was the primary trial endpoint was a efficacy endpoint of moderate to severe acute pancreatitis, which is defined by at least one of local complications, exacerbations of comorbidities, or organ failure. And more importantly, there was also a safety endpoint, and that was an endpoint of clinical fluid overload with dyspnea, fluid overload, or radiologic or hemodynamic evidence of fluid overload. In terms of the primary endpoint, no difference was noted in efficacy between the aggressive and moderate groups. You can see that most of these data kind of favor that the aggressive group caused more problems, but they were not significantly different. And ultimately, the trial was terminated early as a result of safety. So in the aggressive group, fluid overload dyspnea, and signs of fluid overload developed in 20.5% versus 6.3% in the moderate group. And the trial was stopped after enrollment of 249 patients at interim analysis due to this safety signal. So that's just a reminder to us in terms of our management of pancreatitis that we don't need to be too aggressive in terms of fluid management, and we can err on the safer side of things. There is a second trial coming out from this same group. It's called the Water-Land study, and they'll be looking at the role of lactated Ringers versus normal saline in terms of a fluid selection for acute pancreatitis. That study has not started, is currently enrolling, and we as a GI group are currently contemplating whether or not we'll join that trial. More news to come on that. So on to the bulk of our talk. We're going to be talking about pancreatic fluid collections, pancreatic necrosis, and this is the Atlanta classification of pancreatic fluid collections. One of my big pet peeves is anytime someone gets admitted for pancreatitis and they get imaging done and imaging shows any fluid surrounding the pancreas, they're automatically on the chart called a pseudocyst. So everything that has fluid around the pancreas, whenever I see notes written about it, everyone just refers to this as a pseudocyst. And not everything is a pseudocyst. And there are significant differences in how we manage and patient outcomes between what's a pseudocyst and what's not a pseudocyst. So we have your interstitial edematous pancreatitis as your sort of mild to moderate pancreatitis, and then necrotizing pancreatitis being your severe pancreatitis groups. There's a differentiation between less than 4 weeks and a greater than 4-week presentation. If it's less than 4 weeks and it's just a fluid collection, we would call this an acute pancreatic fluid collection. And if it's a necrotic collection, we would call it an acute necrotic collection. The timing of 4 weeks really reflects the presence or absence of a mature wall or a well-defined collection. And typically that doesn't form until the collection is more than 4 weeks old. Once that wall forms and the collection is more mature and is encapsulated, if it's predominantly fluid, that's when we would call it a pseudocyst. But if there is necrotic collection in addition to fluid, that would be walled off necrosis. And again, so not everything is a pseudocyst. Certainly things less than 4 weeks old, we shouldn't be calling a pseudocyst or a walled off necrosis. And between the pseudocyst and the walled off necrosis, the management of this differs very widely. And so we shouldn't be calling everything a pseudocyst when we see it in the chart. So this is unpublished data from the Dutch Pancreatitis Study Group. You're going to hear me refer to the Dutch Pancreatitis Study Group multiple times during this talk. Between them and the Orlando Endoscopy Group, they form the bulk of the research and data that comes out about acute pancreatitis and management of fluid collections. So as you can see, the green bars indicate that there is complete encapsulation or wall formation around the collections. The red indicates that there's no wall formation. Orange is partly and yellow is mostly. And so you can see that at 1 to 2 weeks, there is not much of a wall formed around these collections, but approaching 4 weeks, you have mostly encapsulated collections. By 5 weeks, it's mostly encapsulated, if not complete. And by 8 weeks, you pretty much have complete encapsulation and wall formation of these collections. Intuitively, this would make you think that delaying any sort of intervention until it's completely encapsulated would be safer. And I'll show you some data regarding that in the future. When we're talking about fluid collections, MRI should really be the imaging modality we use to evaluate these fluid collections. And I apologize to any hospital administrators on this presentation if I've cost the hospital quite a bit more money by all the MRIs we're going to get now. But CT scans are good to identify the evolution of interstitial edematous pancreatitis to pancreatic necrosis or to pancreatic fluid collections. But once that's been identified, you need an MRI to really differentiate the two a little bit further. I still would recommend that we get CT scans done for any of our pancreatitis patients at 72 hours if they are not improving, because that will help us determine if there is another process or if any of these collections are starting to form. But once we've identified the collection itself, we need an MRI to help us differentiate a couple things. Number one, the MRI can differentiate between cystic and solid components. So you can see on the left-handed picture that we have a predominantly fluid collection with no solid component there. On the right picture, it's a mix of solid and liquid there. And so the MRI will really help differentiate between these two where the CT is unable to. The MRI will be able to identify the presence of a pseudoaneurysm within the wall of these collections. This is important for any interventions that we may undertake. If there's a large pseudoaneurysm and we go and manipulate these collections, that can cause significant bleed, which would not be able to be treated endoscopically or surgically and would require IR embolization. So very good to identify any pseudoaneurysms before we undertake any intervention, whether that be endoscopic, surgical, or percutaneous. And finally, it'll also help delineate the ductal anatomy of the pancreas and see if there's any evidence of a disrupted pancreatic duct, which again will affect the choice of treatment and our treatment modalities that we're going to employ. That being said, not all collections require drainage. And as I mentioned, of those patients with severe pancreatitis, 30% will have an infected necrosis. And of those 30% of infected necrosis, 39% of patients will actually recover with antibiotics alone and will not need drainage. On the flip side, 61% of patients, despite receiving antibiotics, will require drainage. Stale necrosis only requires drainage if it's causing some sort of obstruction, and that would be gastric outlet obstruction, biliary obstruction, or if it's causing intractable symptoms, be it pain, nausea, emesis, that we think is related to the fluid collection itself and not from the inflammatory process of pancreatitis. In the acute phase, management is primarily supportive care for SIRS and any organ dysfunction. This is a reminder that all our patients should really have early enteral feeding, as this will reduce the risk of bacterial gut translocation. None of our patients with pancreatitis should be admitted NPO. We should get everyone started on clear fluids with instruction to advance to a low-fat diet as soon as tolerated. As well, if they're not tolerating oral intake, they should get NG feeds, and studies haven't shown much benefit between NG and NJ feeds. Of course, if there is any degree of obstruction, you're going to want post-pyloric feeds, and that would be the exception to that. And unless they're showing signs of infection, we can avoid the use of prophylactic antibiotics. So there are three main ways that we can treat pancreatic fluid collections, and historically, this has been a surgical procedure, and that has changed over the last decade or so, which we'll review. But the surgical procedure initially was open necrosectomy, and then came along VARD, or video-assisted retroperitoneal debridement. Nobody, or almost nobody, does open necrosectomy anymore, and if any surgical intervention is to take place, it's going to be a VARD. In terms of VARD, how they do that is they request that you put a percutaneous drain into the retroperitoneal space. And the percutaneous drain is not being used to actually drain the collection, but that percutaneous drain is a conduit for access to the necrotic collection. So you place the percutaneous drain, allow that to mature, and then the surgeons will use the tract of the percutaneous drain to dissect down to the necrotic collection and do their debridement from that area. There's always percutaneous drainage, and as I mentioned, you need to do that prior to doing any VARD, or it will also be used in cases where the collection is not yet mature enough to do a VARD or an endoscopic drainage procedure. And it's also important that we use percutaneous drainage in areas that we do not think will be accessible to endoscopic drainage, that primarily being extension into the pericardic gutters. And finally, the main topic of our talk today is endoscopic cystgastrostomy. So in 2018, one of the landmark trials came out, and this was the tension trial. This enrolled patients from 2011 to 2015. It was a randomized controlled trial, and it was designed as a superiority trial, with the primary endpoint being major complication or death during 6 months of follow-up. And so as you can see here, there were 51 patients randomized to an endoscopic step-up approach versus 47 patients randomized to a surgical step-up approach. There was no difference in mortality, which was the primary outcome, but a reduction was noted in the length of stay and fistulas in the endoscopic group. So in the endoscopic group, these patients were, they used plastic stents to create a connection between the stomach and the pancreatic collection. Versus a surgical, which was the percutaneous stepping up to video-assisted retroperitoneal debridement. There was no difference in complication or death between those two groups. But as you can imagine, since the surgical group required the use of percutaneous drainage prior to the surgery, this created much more pancreatic fistulas in the surgical group. And the mean days in hospital were significantly higher in the surgical group, with 69 days in the surgical group versus 53 in the endoscopic group. So this was the first large, well-run RCT in regards to an endoscopic or surgical approach. And there was the endoscopic group was non-inferior to the surgical group. They took a look at the remaining 83 surviving patients, and this was the extension study. So long-term follow-up of 7 years after the initial tension trial, there again was no difference in mortality or major complications. And they did find that in the endoscopic group, this group required fewer interventions overall after that 6-month follow-up period. Of course, this wasn't the first trial to look at endoscopic versus surgical therapy for pancreatic fluid collections and pancreatic necrosis. There was a smaller trial published in JAMA in 2012. this one was only 22 patients, and important differences were that it was an endoscopic approach versus an open necrosectomy approach and not a video-assisted retroperitoneal debridement approach. The primary endpoint in this study was a bit odd. It was an inflammatory response, and their secondary endpoint was major complications, and that made interpretation a little bit difficult. As you can see by the highlighted boxes there, the endoscopic transgastric necrosectomy group had lower rates of major complication or death and lower rates of multi-organ failure. But again, this trial was a little bit different in its composition. And really the tension trial is considered the first trial to really show that the endoscopic was non-inferior to surgical approaches. Fast forward back to 2019, and we have the MISER trial. The MISER trial is the minimally invasive surgery versus endoscopy randomized trial. This was done by the Orlando group, and the previous tension trial was done by the Dutch pancreatitis study group. The MISER trial actually showed superiority of the endoscopic approach over a surgical approach. It was a randomized controlled trial of 66 patients with confirmed or suspected infected necrosis, and they were randomized to VARD versus endoscopic therapy. The primary endpoint was major complications, defined as a new onset failure of more than 2 organs within 48 hours of intervention, or worsening or new onset of any pre-existing medical conditions in 2 systems within 48 hours of intervention. As you can see, the primary endpoint was 40.6% for the surgical group versus 11.6% in the endoscopic group. And so the MISER trial really hammered home the point that an endoscopic approach was superior and not just non-inferior to a surgical approach. So how do we actually use endoscopy to approach these fluid collections, be it a pseudocyst or a walled-off pancreatic necrosis? And this is done using lumen-opposing metal stents. This has really changed how we do endoscopy these days. And try and mute this.
The catheter lock and moving the catheter control hub downward until the distal catheter is in the desired location within the cyst. Lock the catheter lock. Step number 2, deploy the distal anchor of the stent. Remove and discard the yellow safety clip.
Okay, I can't seem to mute it, but I'm going to pause it there for a second. Essentially, what we're looking at here is the stomach is on this top end here, and then you have your fluid collection on the bottom portion. And you're going to be using your endoscopic ultrasound to identify the collection or the space, and then they will be deploying a stent into that area.
Slide the stent deployment hub upwards until the stent deployment hub locks into place at the white line next to the number 2 arrow. The catheter shaft in the GI tract. Unlock the catheter lock and slide the catheter control hub upwards until at least 2 to 3 millimeters of the black catheter shaft marker is visible in the GI tract. This indicates that the Axio stent is correctly positioned for the final stage of deployment. Then lock the catheter lock. Step 4, unlock the stent lock and slide the stent deployment hub upwards towards the number 4 arrow until the stent deployment.
So you've deployed the distal and the proximal flange, and this has allowed you to create a connection between your fluid collection and the stomach. And from this fluid, from this connection, you're able to actually enter into the collection itself. If this is predominantly fluid, the fluid will drain. If there's necrotic material, you could go in and do a direct necrosectomy. So these are lumen-opposing metal stents, and as I mentioned, this has really changed how we do therapeutic endoscopy and how we complete, how we are able to access different cavities from the stomach or from the luminal cavity. You can see that it has this sort of dumbbell appearance. This allows it to anchor itself between the two cavities. And there's various diameters to these stents from anywhere from 6 millimeters to about 20 millimeters. And this will allow you to either drain fluid or enter into the cavity as necessary. I have another video following this, which is going to show you a deployment of the stent itself into a cavity, and then they'll have some degree of necrosectomy with it as well. So this is Kenneth Binmoller. He's one of the creators of the stent, actually, and he's going to go through identification of a collection and deployment of the stent.
This is now from here a 100% ultrasound.
For CBD stricture.
On the ultrasound, slowly pulling up. This is a 15 millimeter diameter. A bit, so you can see. So I am going.
So he's entered the stent into the cavity now, and he's going to deploy that flange that we saw in the video before.
Okay, I'm going to unlock, and I'm now going to deploy the distal flange, and I just pull up like this while I'm looking on the ultrasound, slowly pulling up. This is a 15 millimeter diameter, so we could use a 20 millimeter, but I've chosen a 15 because there are many blood vessels in the area. But you have to have at least a 15 here. Now the next step is you unlock and pull up your sheath to snug the deployed distal flange against the wall. And you pull it until it starts to deform a little bit. It's deforming. Now I'm going to lock again. So to show you that here, lock again. Now I'm ready to deploy the proximal flange, and I'm going to deploy this inside the working channel. So you just pull up and it's going to deploy inside. You're not going to see this, of course, on the ultrasound, but now that I've fully deployed, I'm ready to switch to the endoscopic view. And only now do I shift my view to the endoscopic image. So please go to the endoscopic image large, and I'm going to start giving a little bit of gas now as I'm turning my body slightly to the right. And as I'm doing that, I'm going to push out the proximal flange. And you see it coming out there. You already see the pus draining. Sometimes you need to advance the gray hub a little bit just to see. I've pushed it out, and you see the pus is completely impairing our view. Look at the pus pouring out. This is why this patient is septic, and this is why this procedure we're doing this morning is going to save this patient's life. So we are doing something.
So he's made the connection between the fluid collection. He had immediate drainage after he put in that stent. We'll fast forward the video a little bit and see if we can get into the necrosectomy portion. Generally speaking, after we deploy these stents, you have two options. You can either let it self-expand, which will take place over the course of 24 to 48 hours, or in this case, they're going to balloon dilate the stent. And they're going to dilate the stent so that they can drive another scope into the stent, into the collection itself, and start the necrosectomy. And so you'll see here that this tube coming in is a balloon catheter that they're going to use to dilate up that tract. And once the tract is dilated, he's able to enter into the collection. And this is what it looks like inside in terms of the necrotic collection.
Yes.
So would you use endorotor now?
No, but maybe in the future session, we
Okay.
would consider using endorotor. So I'm a big fan of.
And so what he's doing here is irrigating the collection to try and release some of this necrotic material. And the process of that, some people use hydrogen peroxide, dilute hydrogen peroxide to irrigate that. In the past, we've used nasocystic catheters to provide continuous irrigation. But these days, we would just leave that in place and bring them back for sequential debridements until the cavity itself is closed, or until the cavity itself is devoid of any more necrotic material. So the video goes on, and he just kind of is irrigating this area. You can see all this necrotic material. Most of the material has been evacuated.
This kind of walled-off necroses or necrotic contents or infected, you must do weekly debridement. You must bring the patient back, keep on antibiotics, keep off of PPI, weekly debridement.
Okay, can nasocystic drip.
So the important part, he said there, was to keep off of PPI. And anytime we do this procedure, we stop all PPI therapy. The reason for that is the PPI will help with auto-degradation, the acid from the stomach will help with auto-degradation of the contents in the fluid collection or in the necrotic collection. And thus we stop the PPI therapy. So that's how the procedure is done. The third major trial that really looked at these procedures is the Pointer trial. This came out in 2021, again from our friends in the Dutch pancreatitis study group. This was a postponed or immediate drainage of infected necrotizing pancreatitis. It was a multi-center randomized controlled trial, and the patients were randomized to drainage within 24 hours of infected necrosis being diagnosed versus waiting until there was walled-off pancreatic necrosis. The primary endpoint was a comprehensive complication index, which was combined complications over a 6-month course of follow-up. As you can see, 55 patients were randomized to immediate drainage and 49 patients to postponed drainage. The mean time from the onset of pancreatitis for the immediate drainage group was 24 days, while the mean time for the postponed drainage group was 35 days. There were 60% of patients had their collections encapsulated in the immediate drainage group, and 70% were encapsulated in the postponed drainage group. There ultimately was no differences in terms of complication, comprehensive complication index score, or secondary endpoints of death or new onset organ failure between the two groups. However, what was interesting was that the delayed intervention group had a shorter hospital stay and required fewer invasive interventions. So if we waited longer, we were able to reduce the number of interventions from 4.4 to 2.6. The length of hospital stay was reduced from 59 days to 51 days. And as you can imagine, that had a significant cost benefit as well, with the immediate drainage group costing about 53,000 euros over the cost of their hospital stay versus 47,000 euros if we waited longer before acting and intervening on the collections. So most of the studies that I've been presenting, and actually all those main trials, the tension trial, the Miser trial, the Pointer trial, all actually took place before the advent of lumen-opposing metal stents. And so in those cases, they actually used double pigtail plastic stents to create a connection between the stomach and the wall and the fluid collection. However, after those trials came out, around 2016 is when the lumen-opposing metal stent was first introduced, and more people started using that. So there weren't any very large trials in that regard, but when we look at the data combined in a meta-analysis, the use of lumen-opposing metal stents are favored both in terms of clinical success and complications. So what complications can occur with the lumen-opposing metal stents? Bleeding, perforation, migrated stent, buried stent, and air embolism. The bleeding is twofold. So we already spoke about the risk of pseudoaneurysms. So if there is a pseudoaneurysm present, you have to remember that these walls, despite being mature after 4 weeks, are still fairly friable and relatively thin. So if there is a pseudoaneurysm there and you irritate that or cause bleeding, you're going to have significant complications. From an endoscopic standpoint, there's not a whole lot you're going to be able to do because that tissue there is quite necrotic. So putting a clip on there is going to be very difficult. I think at best you'd be able to temporize with some hemospray and then send them directly to the interventional radiology suite. The other axis of bleeding, or the other aspect of bleeding, I should say, is that if we leave the stent in for too long, it can begin to erode into the wall, and that can cause bleeding by exposing blood vessels. Perforation, this can be during the procedure, during insertion, if you have misplaced the stent and put it into a different cavity that was not the fluid collection itself, or it could be delayed perforation where the stent itself is it erodes into adjacent cavities. You can have a migrated stent. The stent can either migrate into the cavity itself, or it can migrate down the GI tract. If it's the latter, that's not a problem. These stents are small enough that the patients will pass them on their own in the stool. In picture A, you can see an example of a buried stent where tissue has ingrown over the stent itself, which would make removal of that stent quite difficult and risk bleeding and perforation. And so the main predictor of all of these complications is stent indwelling time. We're going to go back to our friends in Orlando, and this is a retrospective review of 188 patients where they looked at adverse events in patients receiving lumen-opposing metal stents for pancreatic necrosis. In the multi-variable analysis, the only thing that highlighted was that removal after 4 weeks was predictive of adverse events. And then there was also indication that pancreatic fluid collection size of less than 7 centimeters was also increased risk of adverse events. And the thought for the size was that collections less than 7 centimeters in size drain rapidly and thus have a higher risk of buried stent and bleeding. In terms of indication for when to do this, interestingly, the FDA approval for lumen-opposing metal stents states that the collection has to be at least 6 centimeters in size, and that's not based on this data, but that's based on the initial data, and that makes sense given what we're seeing here today. This is a study that came out at the most recent American GI conference, DDW, just this past May. Basically, they looked at whether doing a direct endoscopic necrosectomy at the time that you insert the stent was superior to a step-up approach being inserting the stent and then bringing the patient back for necrosectomy. And they found by doing the necrosectomy at the index procedure, you reduce the number of interventions that you needed. Again, this is only in abstract form, and a paper will be forthcoming on this, so we'll have more information. So the last part of this talk is disconnected pancreatic duct. And we alluded to this earlier, but when you have a fluid collection or a necrotic collection, this can oftentimes cause disruption of the pancreatic duct. And that disruption of the pancreatic duct typically occurs between the body and the tail of the pancreas, because that's where most of our fluid collections arise. You can imagine that if the distal or the tail pancreatic duct is no longer in continuity with the body, that all the fluid that's being produced and all the enzymes that are being produced from that distal or tail portion is going to add into or contribute to the size of the fluid collection itself. And so historically, surgery has been the main treatment option for this, and that's a distal pancreatectomy. It's pretty easy or relatively more easy to just take off the distal end of the pancreas as opposed to other interventions when you're talking about surgical interventions of the pancreas. More recently, however, we've been focusing more on an endoscopic approach, and that endoscopic approach would be leaving double pigtail stents in place long-term. Unlike the lumen-opposing metal stents, the double pigtail plastic stents do not need to be removed after 4 weeks, or they don't have that 4-week risk of increased complications. And so by leaving a double pigtail plastic stent, you can leave that in indefinitely, and that never needs to come out, and that can allow for drainage of the excess fluid created by this disconnected pancreatic duct. So that's what in the GI community we've been doing, but really the studies haven't quite borne that out. So until we have further information, disconnected pancreatic duct really does remain surgically managed. This was a recent trial from last year looking at this issue in particular. This is not from the Dutch group or Orlando group, but this is from Reddy's group in Hyderabad, India. And they looked at patients with disconnected pancreatic duct in a setting of walled-off pancreatic necrosis. So they identified 236 patients with walled-off pancreatic necrosis, and of those, 104 had disconnected pancreatic duct. So they had their pancreatic necrosis managed using a lumen-opposing metal stent, and then they randomized the group to replacing the lumen-opposing metal stent with a plastic stent or leaving no stent in place. And the primary outcome was the recurrence of fluid collections at 6 months of follow-up. And there was no difference between the groups of whether we left in a plastic stent or whether we left it alone. 3 patients in each group had recurrent fluid collections requiring repeat intervention in those patients. And ultimately, there were no significant differences. So really, we don't have good data to suggest that leaving a plastic stent for the disconnected pancreatic duct is going to be too helpful. Despite this, anecdotally, many people do find it helpful. So that's what we're doing in the GI community currently, although we don't quite have the data to support it just yet. So translating all of these trials into clinical practice, that was kind of 10 years of pancreas research kind of crammed into 30 minutes there. This is the most recent AGA clinical practice guideline. This was published in 2020, so it's relatively old now. But even at that time, they said that percutaneous drainage and transmural endoscopic drainage are both good first-line therapies, but endoscopic therapy is preferred. And of those endoscopic therapies, the lumen-opposing metal stents seem to be superior to the double pigtail plastic stents. Of course, that is intuitive in and of itself as well, because the lumen-opposing metal stents do have a larger diameter, so you can do direct endoscopic necrosectomy, whereas that's not really possible with the double pigtail plastic stents. And then in terms of the percutaneous drainage versus endoscopic drainage, of course, you're going to get more pancreaticocutaneous fistulas in the percutaneous drainage group. This is a quick flow chart from that same guideline document. The only thing that I really want to highlight your attention to is that with me saying all this, we still do use quite a bit of percutaneous drainage. And again, that's in cases where the wall of the collection is not yet mature enough for us to intervene, or if there is extension into the pericardic gutters as we are unable to access those endoscopically. And so percutaneous drainage still has a role in the management of these fluid collections and necrotic collections. We went through this as well in terms of the acute phase of management, the late phase of management of acute pancreatitis with necrosis. And what they're highlighting here is that if the collection is in the retrogastric collection, we're going to do a primarily endoscopic approach with the LAMS. If it's retrogastric with a pericolic gutter, we're going to do a combined approach with the percutaneous drainage and the pericardic colic gutters, and then an endoscopic approach to do the actual debridement itself. And finally, to wrap up here, this was another approach pretty similar to what the AGA proposed. And this is from our friends in Orlando once again. So they differentiated the pancreatic fluid collections into your pseudocysts and your necrotic collections. In terms of the pseudocysts, all patients, if there was just the pseudocyst itself, were treated with lumen-opposing metal stents. And that will allow you to quickly drain the fluid collection. If it's primarily fluid, you insert the stent, you can leave it there for 3 to 4 weeks, repeat imaging, and once that collection is completely collapsed, bring them back and take out the stent. On MRI, if there was evidence of a disconnected pancreatic duct, instead of using the lumen-opposing metal stent, they would use the plastic stents. And again, since it's predominantly liquid, all that liquid would drain through. And in that case, you don't need to bring the patient back to remove those plastic stents. They can stay in there indefinitely. In terms of necrotic collections, what they did or what they propose that you do depends on the characteristics of the collection itself. So if it's a unilocular singular collection, you just put in 1 LAMS and do your direct endoscopic necrosectomy. If there are multiple collections that are not connected, you may need more than 1 lumen-opposing metal stent to access both collections and do the necrosectomy. In the case of disconnected pancreatic duct, they will either use a single gate or a multi-gate technique. And once the necrosectomy is complete, replace those with the double pigtail pancreatic stents. And if there's extension into the paracolic gutters, then they'll need combined modality with either a single or multi-gate LAMS and then a percutaneous drain. So overall, if you're going to take anything home, number 1, nomenclature is very important. Not everything is a pseudocyst, and not all collections are created equal. Endoscopic management is really a paradigm for treatment and is really first-line therapy for management of these pancreatic collections. As I mentioned, when the collection itself does not have a mature wall or it's quite early, in the treatment process, or if there's extension into the paracolic gutters, then percutaneous drainage is still our friend and is still needed. We really should not be opting for surgical management or VARD unless this is a collection that cannot be accessed endoscopically and percutaneous drainage is insufficient because of the degree of necrosome and necrotic collection. So that's a situation where VARD may be useful, but really we should be opting for endoscopic management as the predominant treatment modality. And finally, while we can intervene on these collections earlier, before 4 weeks, it's technically possible, but it's not better. The outcomes do not improve if you access these collections earlier. And indeed, from the studies that we've seen, it causes you to need more interventions, has longer hospital stays, and costs the hospital more money as well. And with that, happy to take any questions. Okay, if there's nothing else, if anyone has any questions in the future, feel free to email me. We are doing these procedures at SHN for all our colleagues at Centenary. We've been doing it at the General for the last 3 years. So please don't send these patients down to St. Mike's. Just contact any of us at the General and we'll be able to take care of those for you. Have a great day, everyone.